Welcome to Pediatric Case Review. Today we will explore measles in pediatric practice through an interactive case-based approach. This lecture aims to enhance your clinical reasoning and management skills for this important infectious disease. Let's begin by testing your knowledge with some clinical scenarios. A 4-year-old unvaccinated boy presents with 3 days of high fever, cough, runny nose, and red, watery eyes. Based on these symptoms, what is the most likely diagnosis at this stage? Is it A, influenza, B, early measles, C, allergic rhinitis, or D, adenovirus infection? The correct answer is B, early measles. This represents the prodromal phase characterized by the classic triad of cough, coryza, and conjunctivitis, often called the 3Cs. High fever typically precedes the rash by 3 to 4 days. This presentation is highly suspicious in unvaccinated children, especially during outbreaks or after known exposure. The same child is now on day 4 of illness. On oral examination, you notice small bluish-white spots on a red background on his buccal mucosa. What are these oral findings called? A, aphthous ulcers, B, Koplik spots, C, Fordyce spots, or D, thrush? The correct answer is B, Koplik spots. These are pathognomonic for measles infection and typically appear 1 to 2 days before the characteristic skin rash. They are described as bluish-white spots resembling salt grains on a red background on the buccal mucosa opposite the molars. Identifying Koplik spots allows for early diagnosis before the appearance of the classic rash. It is now day 5 of illness. The child develops a red maculopapular rash that first appears behind the ears. What is the classic progression pattern of the measles rash? A, centripetal spread from extremities to trunk, B, centrifugal spread from head downward, C, random distribution without pattern, or D, simultaneous appearance all over the body? The correct answer is B, centrifugal spread. The measles rash follows a characteristic progression, starting behind the ears, hairline, or forehead, and spreading downward over 3 to 4 days. It typically spreads from face to trunk, then to extremities, and finally to the feet. This head-to-toe progression is a key diagnostic feature that helps differentiate measles from other viral exanthems. 2 siblings who attend the same classroom as our patient present for evaluation. What is the most likely route of measles transmission to these children? A, fecal-oral contamination, B, direct skin-to-skin contact, C, airborne respiratory droplets, or D, vector-borne transmission? The correct answer is C, airborne respiratory droplets. Measles is one of the most contagious infectious diseases with a basic reproduction number of 12 to 18. It spreads primarily through respiratory droplets and airborne transmission. An infected person is contagious from 4 days before the rash appears until about 4 days after rash onset. The virus can remain suspended in the air for up to 2 hours, allowing transmission without direct contact. A 3-year-old presents with fever and rash. Which of the following physical examination findings is most consistent with measles? A, vesicular lesions, B, maculopapular rash that blanches with pressure, C, purpuric rash that does not blanch, or D, target-like lesions? The correct answer is B, maculopapular rash that blanches with pressure. The classic measles rash is erythematous and maculopapular, consisting of flat and raised elements that initially appear as discrete lesions but later coalesce, especially on the face and upper body. Unlike purpuric rashes, the measles rash blanches with pressure. It is typically non-pruritic, which helps differentiate it from allergic rashes. A 5-year-old with confirmed measles is on day 3 of rash. Which of the following additional findings would you most commonly expect to see on physical examination? A, hepatosplenomegaly, B, lymphadenopathy, C, jaundice, or D, meningismus? The correct answer is B, lymphadenopathy. Children with measles commonly develop enlarged lymph nodes, particularly in the posterior cervical and occipital regions. These nodes are often tender on palpation and reflect the immune system's response to the viral infection. While hepatosplenomegaly can occur in severe cases and meningismus may appear with encephalitis complications, lymphadenopathy is a much more common finding during routine examination. A 4-year-old with measles presents with persistent cough and signs of respiratory distress. On chest examination, which finding would be most concerning for a serious complication? A, stridor, B, crackles and decreased breath sounds, C, wheezing, or D, pleural friction rub? The correct answer is B, crackles and decreased breath sounds. These findings suggest pneumonia, which is one of the most common and serious complications of measles. Pneumonia may develop from direct viral infection or secondary bacterial infection. The presence of crackles, decreased breath sounds, increased work of breathing, and hypoxemia requires prompt evaluation and appropriate management. Pneumonia accounts for a significant portion of measles-related mortality in children. A 6-year-old child who was diagnosed with measles 1 week ago now presents with altered mental status, seizures, and fever. What is the most likely neurological complication? A. Meningitis. B. Acute encephalitis. C. Guillain-Barré syndrome. Or D. Cerebral abscess? The correct answer is B. Acute encephalitis. Measles encephalitis occurs in approximately 1 in 1,000 measles cases and typically presents 2 to 6 days after the rash appears. It manifests with altered mental status, seizures, and focal neurological deficits. This complication carries a high mortality rate of about 15%, and approximately 25% of survivors develop permanent neurological sequelae. Early recognition and supportive care are essential for improving outcomes. A 3-year-old presents with suspected measles. What is considered the gold standard diagnostic test for confirming measles infection? A. Clinical diagnosis only. B. Serum IgM antibodies. C. Reverse transcription polymerase chain reaction from nasopharyngeal swab. Or D. Skin biopsy. The correct answer is C. Reverse transcription polymerase chain reaction from nasopharyngeal swab. RT-PCR is the most sensitive and specific test for measles and is particularly useful during the early phase of illness. It can detect viral RNA before antibodies develop and remains positive throughout the course of a disease. While serum IgM antibodies are also commonly used, they may not be detectable until 4 to 5 days after rash onset, making RT-PCR the preferred initial test. A 4-year-old child has confirmed measles. Which of the following laboratory findings would you typically expect to see? A. Leukocytosis. B. Leukopenia with lymphocytosis. C. Thrombocytosis. Or D. Elevated liver enzymes. The correct answer is B. Leukopenia with lymphocytosis. This is the characteristic hematologic pattern seen in measles infection. Patients typically have a low total white blood cell count with a relative increase in the percentage of lymphocytes. In severe cases, patients may also develop thrombocytopenia and mild elevation of liver enzymes. These findings, while not specific to measles, support the diagnosis when considered alongside clinical features. A 5-year-old with measles develops increasing respiratory distress with tachypnea, retractions, and oxygen saturation of 92% on room air. Which investigation is most appropriate as the next step? A. Chest X-ray. B. CT scan of the chest. C. Pulmonary function tests. Or D. Bronchoscopy. The correct answer is A. Chest X-ray. This is the most appropriate first-line investigation for a child with measles who develops respiratory distress. A chest X-ray can help identify pneumonia, which is a common complication of measles. The radiographic findings may show an interstitial pattern typical of viral pneumonia or consolidation suggesting bacterial superinfection. This information guides management decisions, including the need for antibiotics, respiratory support, and hospitalization. A previously healthy 4-year-old presents with uncomplicated measles. What is the mainstay of treatment for this patient? A. Antiviral therapy. B. Antibiotics. C. Supportive care. Or D. Corticosteroids. The correct answer is C. Supportive care. For uncomplicated measles in otherwise healthy children, supportive management is the mainstay of treatment. This includes antipyretics for fever control, ensuring adequate hydration and nutrition, rest, and appropriate isolation measures to prevent transmission. Antibiotics are not indicated unless bacterial complications develop. There is no specific antiviral therapy routinely recommended for uncomplicated measles, and corticosteroids are not part of standard management. A 2-year-old child from a resource-limited setting presents with severe measles. Which supplement is specifically recommended by the World Health Organization for all children with measles? A. Vitamin A. B. Vitamin D. C. Vitamin C. Or D. Zinc? The correct answer is A. Vitamin A. The World Health Organization recommends vitamin A supplementation for all children diagnosed with measles, regardless of nutritional status. Studies have shown that vitamin A can reduce measles mortality by 50% and decrease complications. The recommended regimen includes 2 doses given on consecutive days with age-specific dosing: 100,000 international units for children 6 to 12 months and 200,000 international units for children over 12 months. A 9-month-old unvaccinated infant has been exposed to their sibling with confirmed measles yesterday. What is the recommended post-exposure prophylaxis for this infant? A. MMR vaccine within 72 hours of exposure. B. Immunoglobulin within 6 days of exposure. C. Acyclovir. Or D. No intervention needed. The correct answer is B. Immunoglobulin within 6 days of exposure. For infants under 12 months of age who are exposed to measles, immunoglobulin is the recommended post-exposure prophylaxis, as they are too young for routine MMR vaccination. Immunoglobulin should be administered within 6 days of exposure to provide passive immunity. For children 12 months and older, MMR vaccine within 72 hours of exposure is preferred. Immunoglobulin administration will delay subsequent MMR vaccination by 6 months. A 3-year-old with measles develops persistent high fever and productive cough with respiratory distress 5 days after rash onset. What is the most common severe complication of measles? A. Pneumonia, B. Encephalitis, C. Otitis media, or D. Keratoconjunctivitis? The correct answer is A. Pneumonia. Pneumonia is the most common severe complication of measles and the leading cause of measles-related mortality worldwide. It can occur as primary viral pneumonia or from secondary bacterial infection. Pneumonia complicates approximately 1 to 6% of measles cases in developed countries, but is more prevalent in malnourished children and those with vitamin A deficiency. Early recognition and appropriate management, including oxygen support and antibiotics when indicated, are crucial. A 7-year-old who recovered from measles 6 months ago presents with progressive neurological deterioration, including cognitive decline, myoclonic jerks, and ataxia. What delayed complication of measles is most concerning? A. Stroke, B. Subacute sclerosing panencephalitis, C. Multiple sclerosis, or D. Guillain-Barré syndrome? The correct answer is B. Subacute sclerosing panencephalitis, or SSP. This is a rare but fatal delayed complication of measles caused by persistent infection of the central nervous system. SSB typically manifests 7 to 10 years after the initial measles infection, though the range can be from months to decades. Children infected before age 2 have a higher risk. The disease causes progressive neurodegeneration with cognitive decline, myoclonus, ataxia, and eventually coma and death. SSB highlights the importance of preventing measles through vaccination. You are evaluating several children with measles. Which of the following children has the highest risk for developing severe complications? A. A 10-year-old with asthma, B. A 6-year-old with previous measles vaccination, C. A 2-year-old with malnutrition, or D. An 8-year-old with seasonal allergies? The correct answer is C. A 2-year-old with malnutrition. Young age, particularly under 5 years, and malnutrition are major risk factors for severe measles complications and mortality. Malnourished children often have concurrent vitamin A deficiency, which further increases disease severity. Children with previous vaccination who develop breakthrough measles typically experience milder disease. While respiratory conditions like asthma may increase complication risk, the combination of young age and malnutrition presents the highest risk profile. A 12-month-old presents for routine vaccination. What is the standard recommended schedule for measles, mumps, and rubella vaccination in the United States? A. 9 months and 15 months, B. 12 months and 4 to 6 years, C. 12 months and 18 months, or D. 15 months and 5 years? The correct answer is B. 12 months and 4 to 6 years. According to the CDC and American Academy of Pediatrics recommendations, the standard MMR vaccination schedule in the United States consists of the first dose at 12 to 15 months of age and the second dose at 4 to 6 years before school entry. This schedule provides approximately 97% immunity after 2 doses. During outbreaks or for international travel, the schedule may be accelerated, with the second dose given as soon as 28 days after the first. A 15-month-old presents for MMR vaccination. Which of the following is an absolute contraindication to MMR vaccination? A. Mild acute illness with low-grade fever, B. Current antibiotic use, C. Severe immunodeficiency, or D. Egg allergy? The correct answer is C. Severe immunodeficiency. MMR is a live attenuated vaccine and is contraindicated in individuals with severe immunodeficiency due to the risk of causing severe or fatal infection. Other absolute contraindications include pregnancy and severe allergic reaction to a previous dose or vaccine component. Notably, egg allergy is not a contraindication to MMR vaccination. Mild acute illness with or without fever and current antibiotic use are not contraindications to vaccination. You are discussing community-level prevention of measles with pediatric residents. What percentage of the population needs to be vaccinated against measles to achieve adequate herd immunity and prevent outbreaks? A. Greater than 75%, B. Greater than 85%, C. Greater than 95%, or D. 100%? The correct answer is C. Greater than 95%. Due to measles being one of the most contagious infectious diseases, with a basic reproduction number of 12 to 18, it requires the highest herd immunity threshold of common vaccine-preventable diseases. A vaccination rate of at least 95% is needed to prevent sustained transmission and protect vulnerable individuals who cannot be vaccinated. Recent outbreaks have been linked to communities where vaccination rates have fallen below this critical threshold. Thank you for joining this case-based discussion on measles in pediatrics. Remember that despite advances in vaccination, measles remains a significant global health threat that requires vigilance for early recognition and appropriate management. Vaccination is our most powerful tool for prevention. If you found this presentation helpful, please subscribe to Pediatric Case Review for more educational content. If you have any questions or topics you'd like to see covered in future presentations, please leave them in the comments section below.